right, I believe we're live. Welcome to another really interesting discussion from Redwood City. Really interesting, really excellent discussion. Geez, I've already misspoken and we just started, but really excellent discussion. I know it's going to be great. And it's good we're talking about ADHD because that's something that's appropriate. RED stands for really excellent discussions with interesting people doing interesting things here in Northern California. My name is Shane McLaughlin. I'm a content strategist and communications guy who's had the good fortune to work at several global organizations. And I'm a writer who got my start at Inc. magazine, and I'm still writing and publishing. So keep an eye out next week for an article I have coming out on restlessurban.com. So all my LinkedIn friends will see it, and I look forward to connecting with you on LinkedIn. And that's really what I enjoy doing most, actually, is connecting with people to have interesting discussions and learn and grow and figure out how we can kind of make sense of our professional lives and really evolve and get better as human beings and as professionals. And that's what we're doing today with our guest, Dr. Aaron Winkler, a pioneer in the study of the condition of ADHD, attention deficit hyperactive disorder. And before I introduce Dr. Winkler and start our conversation, I want to give a quick plug for our sponsor, who is providing this great space for us. Let's have a round of applause for Sound Union. Thank you. For everyone on the internet, we have a small but mighty crowd of 3,000 people right here. That was, yep, they're laughing now, all 10 of them. Sound Union is a collaborative space for musicians, audio creators, working professionals, offering high quality studios, co-working spaces, and a supportive community fostering creativity and connection. We're right here in Redwood City, combines professional grade equipment and a dynamic environment, making it ideal for music making and collaboration and networking. So come down and check out Sound Union if you're in the area and learn more at soundunion.com. And thanks again to Sound Union for sponsoring these talks and providing us this awesome space. Okay.
The studio spaces are amazing.
Yes. Thank you.
They're amazing.
And by the way, this whole talk is just...
And also the musicians that get to play with here are amazing.
They're amazing.
Yeah.
And we're just opening up for a musical performance from you.
That's right. Yeah. Like we're,
that's good.
We play music now.
We do.
And we didn't before.
Exactly.
Thanks to Sound Union.
That's how the whole concept works, brings people together to play music. So, but we're also today talking about a topic that's really important because it affects 15 million adults and millions more children. As much as 5% or more of the population has attention deficit hyperactive disorder. The symptoms include problems focusing, racing thoughts, difficulty with small tasks, anxiety. Dr. Winkler has dedicated his career to understanding and even managing this condition in adults. And he majored in psychology, neuroscience, and philosophy at Washington University in St. Louis, spent time as a lighting designer in live music in Washington, D.C., and here in San Francisco. I've probably been in some of the clubs that you worked in there.
I was at the Independent, the Regency, and the Warfield.
Oh, nice. Yeah, I know the Independent, especially. That's great.
Yeah, I was at the 930 in DC, and then when I came out, when I came in here, the film were just gone union, and so they could I was like, oh, but I guess but I got to do some.
But that put you into psychiatry, right?
Sorta.
Okay, well,
yeah, sorta. I was kind of already going that way when I left DC.
No worries. You did your residency at the University of Maryland, Shepherd Pratt in Baltimore, a fellowship in college mental health here at Stanford, where you then founded and directed the first ADHD clinic.
It wasn't the first. They'd actually tried 3 times in the prior 10 years.
Okay.
Because they really struggled to stand up an adult ADHD clinic.
The first successful.
No, actually. Also, mine also didn't work. And I lasted longer.
Okay, that's
the other
good.
ones all lasted about a year. Mine lasted 2.5 years.
Okay, that's.
And the people that I trained are still seeing people, but I don't think it's officially set up as its own now. They're just the people who can take the. Okay. But I think they're set up under other clinics now. Yeah, Stanford struggles to stand up an adult ADHD clinic.
But it's going, and you were a part of the original one of the original concepts, and in your extensive clinical work, you've created innovative tools for understanding and diagnosing and treating ADHD. And you've also presented at international conferences. There's a national task force helping to develop the first national guidelines for ADHD clinical care for adults. And you have a private practice. Dr. Winkler has a private practice in Palo Alto. For those interested, you can find out more at www.aaronwinklermd.com. Yeah. So round of applause, Dr. Winkler. Thank you for being here.
Thanks for having me. Thanks for the introduction.
Yes. Let's start with just the basic question. Can you explain at its core what attention deficit hyperactivity disorder is and how it manifests for for adults and for kids?
Yeah. I suppose it's a good place to start.
Yep.
So ADHD is a collection of experiences that, when in one setting or another, right, like it's very culturally bound in some ways, don't seem to work, right?
Mm-hmm.
And so it starts off with, it's the 1820s in Germany, and there's stories of there's like there's a famous one. One of the first writings about a person with ADHD is a kid who's called like Wiggly Will.
Oh, wow.
I think I'm getting that name wrong. But just like a child that just can't sit still,
Mm-hmm.
right? And there are lots of children who can't sit still, right? It's very normal to want to be, well, right. Like it's not like wanting to sit still in a classroom all day,
right?
Like isn't necessarily the natural state of like a 9-year-old child.
Mm-hmm.
And so then from there it becomes, is it a problem? What is it? What are we even looking at? And people have done a ton of work trying to define this, right? The best we've gotten is a collection of symptoms,
Mm-hmm.
right? It's the stuff that's in the DSM, the Diagnostic Statistical Manual. It's the hyperactive symptoms. There's
right.
9 of those. The inattentive symptoms. There's 9 of those,
right?
And they're somewhat amorphous, right? I mean, they're the way they're even written is very narrative. It's not all that pinned down. Whether someone would, a person who blurts out, right? What does that really mean?
Mm-hmm.
Like, what makes that a problem? Like these kinds of things. And so then you have to go from there to, okay, so it has to, yes, you have, if you're a kid, 6 of the 9 in one or both categories. If you're an adult, 5 of the 9 in one or both of the categories. And then it has to cause a significant disruption, right? Work, social, or other occupational, right? Like that's it has to cause a disruption, not just in one setting, but in multiple settings, right? Okay, so we have that. We have people who exhibit these symptoms and they seem to fit in this category. They don't fit in other categories, right?
Mm-hmm. And this is all in recent years, because Wiggly Will in Germany in the 1800s, up to probably 20, 30 years ago, they just sort of said it's laziness, it's inattention, they're not working hard enough. So there's been a lot of progress, right? It's still said a lot.
That's still said a lot. There's a ton of people who are asking for medication for ADHD. They're just cheaters. They're just trying to because we would all love to just be on stims and get our work done, right? And there's a fundamental misunderstanding in what we're actually trying to achieve with medication, which we should definitely get to at some point.
Absolutely.
But you asked what actually is it, and I can answer that. Some of this is you're not going to read this anywhere. This is my understanding of what it is, and it comes from working with a ton of patients, obviously going through medical school and residency and all those things, but also having outside training in in-depth dynamic psychotherapy. It seems to be a thing that develops. It's a fundamental fear of stillness that develops when you're 4, about maybe 3, maybe 5, because there's some kind of structure in your daily life where some kind of needs are not met, right? And it can be frank abuse. It can be, parents were on drugs, or there was a violent, parent, something it can be like that.
Trauma.
But it can also be parents were working 2 jobs, right? And just weren't available to help, or they were available to help, but because of a mismatch between the needs the child is expressing and the way the parent hears needs, it doesn't get met, right? It doesn't have to be, frankly, bad parenting, right? For whatever reason, a child discovers that there are things they cannot express, needs that they cannot get met. And the best way to manage that is 2 things. One is to just float away from the signals that the needs aren't getting met, right? You're not getting fed? Stop being hungry, right? Just learn to turn off that signal, right?
Mm-hmm.
And you can, right? Like a person can do that. Now you can't turn off the consequences
Right.
of not eating well, right? There's all kinds of consequences. Your emotions are going to be unstable. You're not going to sleep all that well. It's going to be hard to socialize because you're really hungry all the time, right?
But then you cope with it and you develop strategies to mitigate those negative symptoms, but you're still not actually getting any better with your relationships, with your work, with your school.
So food's a really good example. There's many examples: sleep, drinking water, right? Like really common for people with ADHD to do things like sit and work for hours and not go to the bathroom, right?
Mm-hmm.
Really common.
Mm-hmm.
And if you have learned, so the one thing is the float away, and then there's simultaneously that you can achieve some facsimile of maybe attention from parents, or maybe it's some facsimile of increased awareness of your surroundings so that you don't feel as unsafe in the stillness through generating intensity, right? And that's the hyperactivity side. So you do the inattentiveness, that's the floating away, and you do the generate intensity, that's the hyperactivity.
Can we dive into that a little bit? Like what?
Sure.
How else does that manifest?
I don't know if I fully answered the like what is it question.
Oh yeah,
but feel free. No, but feel free. Let's do it.
We can balance the both because hyperactivity. If you have ADHD, can you have AD but not hyperactivity as well?
Yeah, I differ from my colleagues in that. So according to the DSM, there are two types. There's the hyperactive type and the inattentive type.
Okay.
And there are many very competent diagnosticians, physicians, nurse practitioners, like competent diagnosticians that will diagnose somebody as inattentive type or hyperactive type or combined, which is both.
Okay.
In my experience, it doesn't work. It's not really true. And there's interesting data that the attempt to sort of like break it out into pieces has been done multiple times in multiple ways. Like maybe there's an impulsivity piece of it, right? Which sort of then got subsumed back into hyperactivity, right? And it's never been all that effective. In my experience with patients, every single patient I have ever treated that is inattentive type has a hidden hyperactivity. So it'll be perfectionism, or it'll be a mean inner monologue, right?
Sure.
And the reason you're not an 8-year-old that's pushing other kids, and so the teachers see it, and so you're hyperactive in this physical way, is that your hyperactivity is internalized, right? There's an external version, but there can be an internal version, and it's not like I'm so like, how do you? Okay, well, I'm going to get in trouble if I don't sit still, so I need to sit still. And the way to achieve that is I'm so stupid. I'm just like, why am I such a just sit right? And they'll this really mean inner monologue, or they'll develop perfectionism, right? Like it's got to be exactly right. And that in my opinion, that's hyperactivity. It's not going to show up in the hyperactivity parts of the diagnostic guidelines, but in the reality of my patients and in how I see them get better and change with treatment, a lot of that stuff goes away in the same way that hyperactivity goes away, right?
Right.
And it has a lot of the same feel in that it's this sort of like this generation of intensity. It's whatever, in whatever way. It's like stillness is not okay, and so you have to generate intensity in ways that are not adaptive. They're adaptive when you're 4. But they're not adaptive when you're 40, and you're still doing them, right? So like there is a hyperactive type and an inattentive type, and combined, which is both, and there's like that's how diagnostics is done. But I'm strongly of the opinion that it's not that there isn't really that everybody's
elements of everything.
That if you actually look for like that everybody who's inattentive, if you look, you find where they're hyperactive.
And would you say, I mean, there's 15 million people with this condition, maybe more that are undiagnosed adults?
It's 5 to 8% of the population.
5 to 8%.
I don't know how, like, are we up to 380 million? I'm not sure but it's 5 to 8%, and it's persistent, right? So it's like there are persisters and non-persisters. Like there's a whole thing.
And everyone,
but 5 to 8%.
Everyone who, even if you're not diagnosed, probably has some traits at times. We were talking about this before. So a lot of the research and the tools that you're coming up with and what you understand just about how we work and collaborate, could anyone pretty much learn from what you're pulling together in your research and the ideas and tools you're coming up with? Because just because you don't have ADHD doesn't mean you can't benefit from the breathing exercises or some of the other tactics we were talking about?
So, yeah, we were talking a little bit beforehand about
Yeah.
some of the tools that people can deploy behaviorally
Yeah.
to sort of try to mitigate some stuff, right? So one of the big difficulties with ADHD, one of the real hard problems about the diagnostics is there's nothing in any of the 18 criteria that are not, it's all of it is present in the general population. They're all,
Right.
none of them are binary. None of them are on off. Everything is present to some degree as a bell curve or some kind of curve throughout the population. And so then it becomes a question of when is it bad enough that we call it a diagnosis, right? It's true. And it makes it hard. It makes it real difficult.
And just notifications and your text messages and emails, and the world is moving so quick, it's harder to not be distracted even if you don't have it.
So that's an opportunity to say, thank you for that opportunity.
No worries.
So
that's why I'm here.
A really common question that I get is, can you develop it as an adult? And there's some differing opinions on that. But I and many of my colleagues who do this, no, you can't develop it as an adult. You can definitely become addicted to social media.
Sure.
Right. You can absolutely become addicted to your phone, and it will show a lot of the signs of sort of inattentiveness, hyperactivity. I've got to be checking. And if I'm and I'm not paying attention to the person I'm with because I'm thinking about, right.
Yeah.
And that can look a lot like ADHD.
Yeah.
Right. But the thing that separates out, and the name ADHD, then, attention deficit is such a generic word that it's almost unfortunate that that's the name of it, because it's so global that it's hard to, but what separates the clinical syndrome that I call ADHD, that we call ADHD, and somebody who just needs to get off their phone, is the age at which it develops. It has it's difficult to effectively communicate the disastrous effects of building this internal approach to the world at that age and all the consequences of it. One of the things I do when I'm diagnosing, and I learned this from, okay, can I do a bit of a sideline?
Sure.
Okay. So
we're talking about ADHD. We can talk about anything.
So one of the things is there, when it comes to ADHD in adults, there's not training in it, in how to diagnose it.
Okay.
Right. In adult psychiatry residency, usually, because
it's so broad.
No, it's because it was always considered to be a condition in children.
Right.
Right. It's a condition of children. So it is taught, and you do it clinically when you're in child fellowship, which happens after adult residency. And so if you don't do that fellowship, then you don't do it. And you get plenty of lectures about it, right? And you might see it here and there, right? And you might see it in clinic. And but because of the way training is structured, right, the people who train you are the people who are doing the work, right?
Okay.
And so since you're in adult residency, none of them are child docs, and you do some child in adult residency. You got to do 6 months, a year of it. You got to do child experiences, but those can be like the ones I did were like, I did inpatient, right? And that counts, and it's very real.
Okay.
You do some child outpatient, right? But there aren't that many people who are in a position to train residents who have significant experience and skill doing ADHD in adults. So a lot of people coming through, there's not a whole lot of people who can teach it to you. I was fortunate in residency to run into a doc at a conference, David Goodman in Baltimore, and he let me follow him for 3 months. And he had built his own practice doing ADHD in adults and had spent 25, 30 years doing it. And is very involved at the highest levels of trying to move things forward in the scientific community, and doing very good work. Watching him opened a lot of doors for how do you actually diagnose somebody? How do you actually ask them questions? So one of the things that I learned from him is you can phrase a question, you can ask a question without any explanation, right? So, and there's a lot of versions, and a lot of them are, and I've developed dozens and dozens of these, and some of them are culturally bound. So you got to, sort of specific, but like a really good question is how many water bottles?
Okay.
Right. So like I could ask our audience, how many water bottles? Right. And somebody who doesn't have ADHD is going to say, how many water bottles what? Right.
Mm-hmm.
And somebody who grew up in a place where, they played on sports teams and sports teams had water bottles.
So they're going to have an answer.
They're not even going to know. They're just going to laugh.
Okay.
Right. Because the answer is you couldn't count. The answer is so many that my parents stopped buying them for me, and the coaches stopped letting me have replacements, and I just had to use I just had to use like I had to use the disposables, right? They won't even answer the question. You can ask like, what do you do when you lose your credit card, right? Which doesn't work as much in the younger population because they're all they've been on Apple Pay for such a long time, right? But somebody with ADHD, right, who's maybe over 35 or over 30, right? A normal person, when they lose their credit card, what they do is they cancel it.
Right.
That's just, they immediately, the moment they know it's lost, they cancel it immediately. Somebody who has ADHD is not going to do that because they did that the first time. And then they found it in the couch. We have an audience member or two. Yeah.
Hands going up here.
Multiple audience. So, yes. So right. So like so
you're going to find it. You have that positive.
So what they do is, they have a second one, because the first time they lost it, they canceled it, and then they had to redo all their auto pays. They had to redo all their bills. They had anything that was like, and it's such a pain. And then they found it in the couch 3 months later, right? But
they're taking a risk, and that might be the impulsivity, right?
Because
they don't know. Maybe they lost it in the street. And someone's
you're wrong.
Charging up a Lexus with it.
Because that's the thing is it's not because
in the back of their head they know.
People with ADHD develop a sixth sense.
Okay.
For when something's really gone, right? You'll know. You open your closet. Watch me go. Like, here we go. Ready? Like, here we can go. Right? You open your closet, right? And your coat's not there. And you look in your closet and there's and your coat's not there, and you don't know why your coat's not there, but you have ADHD, so you lose stuff all the time.
Yep.
So you're really used to stuff just not being there, right? So you've built a whole thing where like, okay, where's the last time I saw? Okay, and you think back, and you realize it was 4 days ago in the park, and you had it, and you took it off because the sun came out and it got hot, and then you walked 30 feet away with the person you were talking to because it was nice to go sit by the water, and then you both said goodbye, and that was the end of the thing. And because now it was hot, you didn't need a coat anymore, and so you just left.
Yep.
And the immediate thing then is like, that's gone.
Yeah.
That coat,
so you would know.
Gone. Not even going to bother going to look for it. Gone. Right. But there's this other thing where it's misplacing something, where you know that it's going to show up in the towels.
Right.
Like, you're going to unfold the towels from the beach and the credit card's going to fall out, right? Like, you can look everywhere for it, right? And you're going to find the sunglasses in the refrigerator. Like, there's no reason for those to be there, but like, right?
That probably happens.
And so what they do is they just have a second credit card, and you can get online and you can check to see if anybody's using it, right? But after a while, people stop doing that too, because they know nobody's using it, and they'll just use the other credit card till the first one shows up again.
But with your goal in your treatment of folks like this is to create tools and help them not have to have two credit cards. And can you talk a little bit about? I love the fact that there was a good response when he told that story, because there's a lot of understanding of what's going on, because we all misplace things. How do they get?
That's the thing is, we do all misplace things,
and we can all learn from how we could be better.
Well, right. So there's simple tools, right? But most people, when they misplace things the first time, right? They learn.
Don't do it again.
They learn ways to not misplace things.
Put it in the same place.
That's the answer. The keys never, ever, ever go anywhere except that hook or this pocket.
Yep.
Right? They are never anywhere else. Right? And for most people, that's not hard. because they're not doing the hyperactive thing of I should always have 4 things in my hands.
Right.
Right. I've always got it. And then I've got,
you need to have,
because I come
the keys
inside and
in
I
case you
take
need
the
the
keys
car.
out of my pocket,
Yeah.
but I'm also still holding the water bottle. And then I really would like a banana right now. So I'm going to get the banana, and because I haven't eaten in a really long time. Oh, and now I need to pee because I didn't pee before. And like I'm going to have to leave again in 15 minutes. So I better pee real quick. And now I'm putting everything down. Like I've got a banana and a water bottle and my keys, and they're going on the counter in my bathroom next to the, right?
Yeah.
Which doesn't make any sense. But then like, and then it falls in the toilet, right? Like, so, right.
Yeah.
Right. So yeah. So people.
So
somebody in the audience has a tile on it, right? So
that's smart.
Yeah. So
my wife got me that. Yeah.
Yeah. The app. Yeah. So those are great, but you can also just always put it on the hook, and you have to build in this very specific behavior of nothing ever leaves my hands unintentionally, ever. I never ever put something down without it going where it goes.
But with the ADHD person, that's a task that they don't want to do, and it feels better to have those keys, right? What you're doing is training them to go back to every time, put it up there.
Well, so
it seems so simple.
Well, so this is where we get into the steeper thing.
Yeah.
Which is, and this is like Shane asked me when we were chatting before we started about CBT.
Yeah, let's talk about that. That was next on my list, in fact.
Right.
Yes.
Like we can do perfect thing. Like
cognitive brain therapy.
Cognitive behavioral therapy.
That's why you're the doctor, not me. Thank you for that.
Well, because it's different, right?
Yes,
because cognitive brain therapy would be like neurofeedback.
Yes.
Cognitive behavioral therapy, it's much more about like, I always put the keys in this place, right? Mm-hmm. If you are still afraid of stillness, right? Yes. It's about where that sits. That's why developing at 4 is so important, right? Everything you read about developmental stages, Freud, Piaget, and there's Erickson, like it's always 0 to 5, right? It's always like the developmental stages up until somebody's about 5. And anybody who's got a kid, who's seen a kid become 6 and get into like, it's usually like enter kindergarten, beginning of 1st grade, right? Where before then they feel like a person. They really do feel like a person, right? But then something happens, something changes, and they hit 6. It's right after they do the real or not real thing. It's right as kids are developing the capacity to discern reality from like that there is a thing that is real and something else that's not real. The kind of thing that gets written about in these, developmental things, then you think like, how could, we know what a kid is? But then if you have a child, it's like mine, there was a period of time where all 3 of them different, there was a period of time where they go through this, like, this very specific memory of watching The Land Before Time with my son. And he's like looking at, and he looks at me and he looks at the movie and he looks at me and he goes, is this real? And it's cartoon dinosaurs, right? But in a way it's real because it's a real movie, right? But like, no, Littlefoot's not real, right? Not like he doesn't exist outside of this animation, right? Yep. And up until there's a stage at which the brain matures to a place where it can discern these things in the same way that like an 8-year-old child can't, if you try to speak to them about things that are post-pubertal, right? They literally can't perceive them like you can't until
they go through.
Right. Like exactly. Like you can't tell an 8-year-old child why a 16-year-old is going to make the choices they're going to make. Right. Because they'll think they're crazy. Right. It just won't make sense to them. Right. And the same thing is true. You try to tell a 16-year-old, like what a 27-year-old will do. Yep. And the 16-year-old, like, can't put, which is why you can't run a car till you're 25, right? So this is the same thing. It's right after that they kind of like become a person in this, like, it sort of like congeals in this way. It's right around the beginning of 1st grade for a lot of kids, and you'll see it as a parent, right? They like land in this way. Everything before that is now unconscious. Right. Everything up until then, like like the unconscious is not like a mystical hooey gooey thing. It's very straightforward. Think about when you're 3. So audience members are asking, right? Like, so I see, like, right. Think about when you're 3. You may have flashbulb memories. A lot of people do, right? You may have like
a false memory.
No, not a false memory. Just like a one-shot memory.
Okay, one little snapshot.
Like you probably remember the layout of, like, if you lived in one home from the time you were 0 to 5.
Okay.
You probably, and like in my case, like we moved when I was 6, right? Right when I turned 6. So I was in that one house, 0 to 5, right? I know exactly what that kitchen looked like. Exactly what it looked like. I know where the table is. I know
Sure.
where the sink is. I know where the like the bend around the corner to get to the stove, right? Like I know where all that stuff, right? But process memories, right? Like the actual process of your parent preparing you for preschool, right? The actual
Right.
like what were the stages of getting you from dinner to bedtime, and how long did that take? And right, like if you think about that when you're 10, you probably do remember some of it, right? You probably do remember that process, right? There's much more like real memory there, right? So, but everything before that like 5 or 6 thing, wherever that lands for kids, is now sort of like sequestered. It's like a new brain thing grows over the top of it, and
Right.
everything below is now unconscious, right? So because, and it also answers your question about like why can't you? Well, I'm not sure you even asked her if I just used as an opportunity to say it. Like why can't it develop as an adult?
Yeah,
right?
that was in my
Because the
questions to you.
right. So the fund and like it comes back to like why can't I just put my keys in the same place?
Right.
Because the driving force that generates the hyperactive behaviors, because you were 4, it now sits in an unconscious place, right? So you can gain access to that stuff, but it's not easy and it's not always comfortable. It's definitely possible, but now we start to get into this really interesting space of like, what can you gain access to?
Exactly.
And
how do you
then,
bring it out into your adult mind? Because obviously, if it's there, it could be really beneficial to mitigate some of your symptoms.
and then right, and then there's also a piece of the his name is escaping me, but the body keeps the score. Vanderkolk, thank you, Vanderkolk. Yeah, Bessel Vanderkolk.
Yes,
Nice.
Patrick.
There's a piece of it which isn't just mind; it's also body, right? It's a lot of it's also how do you bring it into your body, right? So how do you bring into your body that when I walk into my house, I cannot necessarily rely on my mind.
Right.
If I could somebody with ADHD, this is a part of why CBT is a struggle until you get them to a certain place in treatment. It's why medication can be, in my opinion, for a lot of people. I had one patient once who managed to really fix it without meds.
Okay.
It was astounding to behold. But everybody else, medication is the thing that, and you have to do it right, and you have to use,
Yeah, exactly.
which we can talk about.
Right.
Because there's a lot of ways to do it wrong.
Right.
But if you do it right, then it settles that thing down, right?
Mm-hmm.
And until that inner thing is settled, your mind is always operating at this like So if you're saying you're supposed to use your mind when you walk in the house to remember to put your keys in that place, but you just are running inside because you're already late for your next Zoom meeting and you still haven't used the bathroom and you're holding a bunch of stuff and you're just throwing it because you got to get there, right? Like you're not going to use your mind, right? Like that's not like the whole point is your mind is not an effective tool for this.
And that's a good lead into CBT.
Yeah.
And, those two things. I want to talk about two things.
Out of CBT.
I'm sorry. Well, and I know there's a lot of questions.
Do it.
Okay.
Do it.
We got about 30 minutes in. Questions in the room too. We're going to get to those. So hope you have them. If you do have a question, you want to ask at the microphone over here so they can hear you online. And we want to take questions from the internet. Do we have any questions from the internet? Okay. We might. Last time we got a few. Yeah. I wanted to ask the two things to cover is like CBT then. Is there some way to apply that so when you go in the house, you don't end up thinking about that appointment and forgetting about all the things you need to do to stay organized?
So yes. So like in theory you could,
Mm-hmm.
and I see no reason to say you can't. Like if you can do it, and do it, go to it, right? In my experience with patients, the cacophony created by the continual experience of the hyperactivity and the inattentiveness is such that it makes it very difficult to actually use those tools in a consistent way. Because like in the scenario I just described, right? Like if you could come home 10 minutes before your next thing and you already used the restroom where you were and you've eaten that morning, and you like and like, sure, if all of those things, then you could like just stand at your door and put your keys down before you walk into the house, right? In my experience, the cacophony created by ADHD that doesn't have the benefit of medication is such that it makes it really, really hard to use those tools. And then the real value of the medication is not that it fixes everything, because it doesn't. The real value of the medication is it calms the system down enough that you can then learn those tools, right? Like it's not the end point.
Right. And can we talk about medication too? Because it seems like what you're advising is.
Does the audience want us to talk about meds? Yeah.
A lot of head shaking.
Yeah.
And it's a balance between meds and behavioral therapy. But what's your opinion? Because there's so many meds out there, and there's so many ideas on like how you use them and what's good and what's not. What is your advice in terms of navigating that world of medication?
So this is a place where it's nice that my clinical experience matches exactly with guidelines. And for some reason, even though they're clearly in the guidelines at multiple organizations across the world, it somehow just does not land. I used to say for a while when I was getting started, because I didn't want to be too black or white about it, right? Like I didn't want to be too categorical about it. I would say if somebody if there's a situation where it makes sense to do short acting meds, like I'll do that.
Okay.
And I know if there is an audience for this, right? Like online, I'm sure there will be people who they take short acting meds and it works for them and it's great, right? Or parents whose kids are on them, works and it's great, right?
And those, is that like Concerta, or what specifically is a short acting versus long acting?
So Concerta is a long acting.
Okay.
It's so there's three broad classes of medications. There's there's stimulants and non-stimulants. And I'm sort of putting non-stimulants. There's two classes of stimulants. There's the methylphenidates and the amphetamines, right?
Okay.
The methylphenidates are Ritalins.
Got it.
And like Focalin and Concerta is the long acting methylphenidate. And there's others. And then the amphetamines are Adderall. And there's a bunch of those things, but like it's the Adderalls, right? And then there's a long-acting version of Adderall, but there's another one called Vyvanse, which is that's the one I like the most for patients for very specific reasons.
Okay.
The child docs really like methylphenidate.
Okay.
Because they think that they really like Ritalin because they feel that there's less side effects. That hasn't been my experience. They also like the child docs. I mean, the child docs, like the way it is done in this country is you start with short acting meds.
Okay.
And in my opinion, that's wrong. In my opinion, there's never a situation. I still haven't. I'm sure there are situations, but I have never. And if anybody's listening to this and you are on a short acting medication and it's working for you, like, do not feel like I'm saying you should stop that. Like, don't. Like, if you've got a situation that's working for you, like, stick with it, right? It's hard enough to find answers.
Exactly.
For patients that I'm starting meds on for the first time, I've never been in a situation where there's a call for a short-acting medication because there's a really important component of the experience of having ADHD is the constant sense of like not really knowing where you are, right? Like, and not knowing your circadian rhythm is totally out of whack, and you don't know when am I hungry during the day, and right, like there's this constant
like forgetting to drink water, like you said,
right, or staying up until 2 a.m, and now you got to get up at 7. No, it's just like there's no stability and consistency, right? The short-acting medications will last for a couple hours, and you'll get like, an hour if it's coming on, and then an hour or two if it's working, and then an hour if it's crashing, and then you take another one, and it's coming on, and it's on, and then it's crashing, right? And if you have a long-acting medicine that's smooth, you just take it once in the morning, and it just works.
It's easy, you're done.
You don't have to carry it with you in the day. You don't have to like try to think about it and time it during the day. And again, like there are people who've been on meds for a long time and are on short-acting meds, take them multiple times during a day. It's a good fit for them. They don't experience a crash as it's coming down. I'm not saying that's a bad thing. When I start patients on meds, you get them on the right dose of a long-acting medication they can take once in the morning, about the same time every morning. And in addition to having the benefit of soothing the fear of stillness, because it gives you like it's essentially what it is like somebody's hyperactive because they're like, I need intensity to feel still, right? I need intensity to like
need to be occupied,
that I'm paying enough attention or I'm going to miss something, right? Like gotta generate intensity, and you just give them that with a medicine, like just give them the intensity, and then their whatever lower brain centers, like reptilian brain, basal ganglia stuff, whatever lower brain centers are generating this like need for intensity that's a little bit below consciousness, so real hard to manage, just feels like there's enough intensity, and then they're calm, and a lot of the behaviors just evaporate, they just melt away.
And we talk about ADHD folks being very creative.
But let me say, but then the other benefit you get is circadian normalization. That's like you get this incredible benefit of circadian normalization where you will be hungry, like you take it at 7 a.m. every day. You'll be hungry at 10:30.
You'll go to bed at the normal time.
You'll be hungry for dinner at 5. You'll be tired around 8, right? And it just becomes this very consistent, regular thing. And that has a lot of benefits on its own, separate from the,
and some of the traits of ADHD are more spontaneity. Impulsivity is the negative thing to say, but spontaneity is the positive way to kind of position that. Creativity, bursts of creativity in multiple projects. Once you get that to that sweet spot between the behavioral and the medication, do you find that people can be extremely productive and be able to multitask and be more creative and successful in their careers? Like, is that, I know that's the eventual outcome that everyone wants to get to, but how do you manage that?
The question is phrased in a way that suggests
there's a light at the end of the tunnel.
No, in that there's another place to get to.
Okay.
That is not.
That's not going to happen.
Go slow to go fast, right? You have to go slow to be smooth. Like slow makes smooth, and smooth makes fast, right? That's like a classic, right? Approaching things in a calm, structured, organized way. I'm trying to like, how do I explain this in a way that makes sense to you? People with ADHD struggle to automate behaviors.
Right.
Biochemically, like I haven't seen data on this, but it makes a lot of sense to me. I mean, I've summed it, but like I haven't like seen it very focused, but it makes a lot of sense to me. Like we know that it takes about 15 minutes, 20 minutes of continual behavior for brain circuits to activate in such a way that they activate your cerebellum, and then they start to get laid down in automatic behavior, right? So walking, right? How long did it take you to learn how to walk? How much consistent attention, consistent focused attention did you have to expend to get to a place where walking was automated? Realistically, like a solid 3 years, right? It was from the time you first got up on your feet, right? And could like barely manage balance, right? From then until you can run without even thinking about it, right? You can even, right? It's like 3 years, right? Because until you can then run, and also while you're running, like be of the presence of mind that like I now need to like look both ways before I run into the street, right? So now it's fully automatic. I can run, I'm running, and I'm also, my mind can like know that this is a road, right? Like it's many years, right? What will make it so that you can multitask, right? So that you can be so productive, so that your mind can be free to be creative, is getting to a place where
your voice is very soothing.
It's getting to a place where the things that you're struggling with now are operating on automatic.
Right.
The way that brushing your teeth at night is, where it's like you floss, you brush your teeth, and it happens
What's
so
a routine,
quick.
right? And that's the basis of anyone. Ben Franklin said it. But your daily routine is going to set your course for the day.
But if the only way that you can achieve routine behaviors is with hyperactivity,
exactly.
That's going to sabotage learning in that way. And so it becomes, so then as you get further in your professional life, right, people with ADHD are very used to, there's like this ceiling where they can fly by the seat of their pants, and they're smart enough, they're whatever, that they can get to a certain level. But then all of a sudden they get to this place, and these other people who were never as smart as they were are now surpassing them. But it's because they've now automated a ton of behaviors.
Right.
And the people with ADHD, every time they walk into a room, they're
They
like
reset.
having to
They have to
build
do
the
it
whole
again.
thing from
Yep.
scratch, right?
Okay.
So the answer is it's going to be pretty difficult to fly at the speed you want to fly at.
Right.
If you can't accept walking for a while. Right. And then learning how to, right. And so that's, I don't know if that gets it across. Like, it's really, there's this deeper place you have to get to. There's this sort of letting go of the, like, I'm just going to, I don't know, start my business now, right? Because if you're a disorganized person with ADHD who's tried that a bunch of times, then you like can never put it. I mean, a lot of entrepreneurs, they like do just fine, right? Maybe they have some ADHD traits, but maybe they're organized, right? What a perfection, like, and it works for them, fine, right? But if you're a person that has struggled with that, and that's why you're looking for help, you're like wondering, do you need a medication? You're wondering, should you treat your ADHD because you're starting to have these problems, right? Like, you may have to let go of starting your business right now, and instead, like, stop at your door and remember to put your keys on the hook, right? For like a while until it gets on automatic. And then you can stop every time you go out of the house, be like, where are my sunglasses? Are they in the refrigerator again? Right? You know? And then you're free, then you can free up your mind becomes free to be creative.
That's great.
I don't know if that answers the question.
No, I want to ask one more question. We have questions in the audience. Yeah, we want to do. All right, should we just go? Because one question, there are a lot of parents here. So okay, so I'm going to ask this question because they're for their parents here, the parents online. But please, if you want to ask a question, go ask at the mic. So I'm giving people a little buffer here to. There we go. Neil's up. But my one question for parents: what can parents do when?
Oh boy,
I don't want to without going to. On a long explanation, one thing, one behavior as a parent, one thing.
Oh man,
a parent can do.
Oh, I love it.
All right,
I thought of it.
Good.
You gave it to me. I've never been able to. That's great. You're gonna hate it. You really want to know?
Yes.
The one thing a parent can do: treat your own ADHD.
Wow. Okay. Neil, what do you got?
You want me to say why?
Okay. Go ahead.
Remember that thing I talked about at the beginning, the mismatch? The thing I talked about, like, there's a 4-year-old kid and they're asking for something and the parent's desperately trying to be a good parent,
right?
But for some reason they can't hear it. And so they're not able to provide.
Yeah.
If a parent has ADHD and the child is saying, Dad or Mom, like, I'm anxious and I need stillness.
Right.
And the adult is like, no, stillness is unacceptable because stillness makes me uncomfortable. I don't know how to do stillness. We need to get into action, right? Like, we can't possibly be still. The child will learn that stillness is not safe, right? There's so many components of the ADHD experience that are very difficult where the child will be asking for something and the parent won't know how to. I mean, a lot of my patients come to me as adults because the kid got diagnosed.
Right.
And while they were going through the diagnostic process, the parent was sitting there going like, that? And that too? And also that? Like, and then they come to me
Sounds
saying,
familiar.
like, right.
Apple does not fall.
Do I have ADHD? Oh, did I? Yeah, that's fine. Like, do I have an ADHD? Like, do I have ADHD? Right. But then as I'm treating them, right? Like, once they because there's this thing where it's like, I don't want to medicate my kid, right? Like, it's terrible. Like, I don't want to do that. I'm turning them into a robot. I'm going to take away their creativity and take away their personality and all that stuff. And if you medicate them wrong, it absolutely does do that.
Yeah. I've heard that.
But if you medicate them right, and once a parent has experienced the difference, once a parent has experienced what it's like, the freedom that can come, the much more like self-aware and actually connected ability to like be present with themselves and with others because they're on a medication that works for them in this specific way, then it's much easier to like help the doctors that are trying to help your kid make choices and watch your kid and be able to see, like, and if you've tried medicines yourself and you're like, I can now tell why this was a bad fit. I can see why, like, I was having this experience and like, that's not right. Like, you'll be able to see it in the kid and it's much easier to help treat your own ADHD.
That's fantastic. And I love that we got people lining up. So Neil, go ahead.
Super interesting. So 2 parts of my question. My learning.
There he is. I think repeat. Yeah, go ahead.
Question. So the conclusion is it's the parents' fault. But seriously,
That's
so-
why this is always hard. It's like because there's like how do you like it's not really
well,
right.
yeah,
Because
this
what it
case
is,
it
you know,
is,
what
yeah.
it is it's civilization's fault.
Yeah, right.
What it is we're asking humans to raise young mammals that need to be raised as like young mammals the same way like an elephant or a
Yeah.
monkey or a giraffe
We got to
would need
run
be
away from the
raised, right?
tiger on the
But you're
Serengeti,
supposed to
right?
do
That's
that
why
while
our
you're
brain works.
also like putting them in daycare because you have to work, right? Like it's not the expectations aren't fair.
Well, so I kind of it was in jest, but you grow into it because of societal. Is that unanimously and medically accepted as the
What?
root cause? The fact that it's not something that you're born with; it's something that you grow into because of the interactions when you're at that age.
Yeah, so it's both, right?
Okay.
So it's there's a genetic biological propensity or ability to develop an ADHD, right? Alongside a situation that then like brings that out. The same, it's like the same with there's like the 2-hit hypothesis in
Okay.
cancer. It's like it's a mixture of nature and nurture, right? So
Okay.
so someone who grows up in a very specific setting that would develop an ADHD, but they don't have the biologic thing, right? They may not develop like, so there's people who, they can't do the intensity thing, right? The
Right.
solution of, okay, well, if I just generate some intensity, that'll solve it, right?
Right.
But if somebody is biologically geared toward an anxiety, right? They're not going to be able to generate intensity to solve it because that will make them anxious.
Right.
Right. And so the very same upbringing situation might in somebody develop an anxiety. Right.
Right.
So there's definitely a biological piece to it for sure. And then there's an additional biological piece that comes with the development as it's like sort of developing into like this is now going to be ADHD. There's additional like sort of neural wiring that happens as you sort of grow up into it, right? It's very much both. It's very much nature and nurture.
And that was the kind of other part of my question is, can you grow out of it?
So that's a really interesting question. There's some data that suggests maybe you can. It's really hard to do those studies. Some of those studies come from clinics because you have to like, how are you going to do that study, right? You got to have a childhood cohort that you can then follow into adulthood, right? But all the childhood cohorts for things like that are kids who have like real bad ADHD, right? Because that's why they're in a research study when they're 9 years old, right? What we do know for certain is that, surprise, surprise, just like aging across the board, the inattentiveness, the hyperactivity goes away, but the inattentiveness doesn't, right? You just kind of, you get old, you get tired, right? You sort of run out of energy.
You float away.
Right. Yeah. So as you stop having the youthful energy to generate the hyperactivity, a lot of the hyperactivity will start to go away, but the inattentiveness will persist. Oh boy, there's a lot of like maybe if you successfully become move into a life where your ADHD is actually incredible, like become a stand-up comedian, right? Become a professional athlete, a space where whatever ADHD you have is treated by, right?
By hyperactivity.
Or just like a high level of activity, right? But then there's also like a lot of examples of athletes will get injured, and then they can't be athletic, right? And there's a depression that comes with that for lots of athletes, regardless. But there's others that then will have an ADHD show up.
Got it.
That was always there. Sorry, we got
no worries.
Sorry.
No, that actually.
We got about
works.
we got about 6 minutes.
Did that answer your question?
Yeah.
I was gonna say that works really well with my question because I was gonna say, looking at comorbidities like with depression and anxiety and everything like that.
Oh yeah, it's party.
Are there SSRIs that work with depression and ADHD to lower those symptoms?
It's a good question. So there are some newer ones. Was that your question?
Yes. It was about, like,
yeah.
It was about anxiety and ADHD. Sorry, but yes, to put, I guess, just a little bit more sprinkles on there.
We're going to sprinkle more a second question on the first question.
Sure.
Yeah.
Absolutely.
Right, because I forgot all my other questions.
We're going to make a question cupcake.
But
we can. Let's do it.
I am curious about anxiety disorders and ADHD and like really and how,
We're sprinkling more. We're sprinkling more.
This is great.
and
That's what we want.
treating the anxiety disorder if that can also kind of bring down the ADHD. And how they're kind of related or not. And then I have another question.
So this is where we get to a place where the reason I started where I started, it's just a collection of symptoms, right? And we're doing our best to like categorize that as something. But at some point, we have to acknowledge that these are human beings with a human experience, which is both individually bound, culturally bound, right? There's all kinds of things about like what in this person is going to be anxious, whereas in that person it's going to be totally fine, right? Like somebody could be like a hoarder, right? And they're a total mess. And that exact same person could, or that exact same approach could like start the Oxford English Dictionary, right? Because it's just like this incredible perfection, right?
Yep.
It's at some point it's really important, I think, for psychiatrists and anyone who does this kind of work, psychology, anybody who does this kind of work, to acknowledge that these diagnoses are not diseases, they're disorders, right? These are collections of symptoms, and we're doing our best to categorize them into different things so that we can do research. Because if we can't do research, like how do we determine if treatments work or not, right? Mm-hmm. So we're doing our best to be like, okay, so we can say all these people fit into this box. Okay, so good. So we've got a box. Now let's try this treatment on it, and like see it, like maybe this therapy or maybe this CBT or maybe this medication. Let's give it a shot in this box, right? But the reality is, real people very rarely fit so neatly into any of the boxes. And I've had patients who have significant anxiety, and they also have ADHD. And the only way to really land is like, they're really struggling. They take an ADHD medication, and they've like their lives get incredibly better. Ooh. They feel better. The people around them sense them as better. They're not, like there's just a lot, but they're still like really anxious. And you give them an SSRI for anxiety, and then that gets way, way better. And they need to be on both, right? Mm. There's people for whom, and the question about like, are there SSRIs, right? So, we don't really know how these medicines work. Right. We can do things like test how they bind to specific receptors. Right. We can do right. But we know lots of things about how those receptors seem to adapt very, very quickly and go back to their initial state, like almost right away, right after being exposed to the medicines. And then yet somehow 6 weeks later, you get better. Right. There's a ton of stuff where the biochemistry that we can do is at a certain level of organization, and then trying to like translate that through, from the molecular level, the enzymatic level, up through like into consciousness. I mean, there's, tissues, wow. organs, right? Like circuitry, pathways, like different organ systems, like trying to like, and then there's like all the other people you're interacting with. I mean, it's, right. You're in a milieu, right? Like trying to go from the molecular biochemistry to like, what's it actually doing in your brain? And is that actually helping? That's why there's still a lot of art in this. Okay. Because it's too much so far, right?
We are complicated creatures.
But that's why this is also really great work.
Yeah, it's really interesting.
Because when you can help some, because you get it's so great to help people with this stuff.
Yeah, absolutely. Becky, did you have one more you want to do?
Oh well, let me wait. I'm still going to answer the like. So there are some newer new SRIs that have higher dopamine action, right? And there's even meds from other classes like that I've tried. Like, so when I was first, I think I was still in med school. Might've been in residency. I was probably in residency. And I was going to conferences, and it occurred to me like, this is a dopamine problem. We've got all these, what about Parkinson's drugs that are like specifically about dopamine? Wow. Like, why aren't we doing that? Right. There's a really interesting one called an MAOI, monoamine oxidase inhibitors. They're old school antidepressants. They're the oldest ones, before even the TCAs, the tricyclics. And they're real problem. They're also by far the most effective, but the side effect profile's real sketch, right? Like it blocks the processing of tyramine, which is in green leafy vegetables. And so then you can be on these medicines and you eat green leafy vegetables, like you just like eat a salad, and you can go into shock. Wow. Yeah, you can go into like total serotonin, right? Because not serotonin, you go into like a norepinephrine like burst, but it's because the pathway then like will create a bunch of serotonin, dopamine, right? Well, it's I don't want to like, I wish I had like a chart in front of me so that I could like be very precise about. But anyway, they were, one of the things that the MAOIs were really good at was atypical depression. And it's one of the ways we came up with this idea of what is atypical depression, is because for some reason the MAOIs worked really well on it. And one of the very specific symptoms of atypical depression was rejection sensitivity. Has there ever been a more ADHD, right?
Yeah.
That like somebody says something nice and you are like on cloud 9 for 3 hours, right? Somebody intimates something wrong and you're like crashing, right? Okay. And then how much of that is because you didn't eat and you didn't sleep, right? And so you're just, you're already in this like, and how much of it is because you're in your head more than your body. And in your mind, emotions that come from thoughts are just much more fungible, much more like they're much more, they have much higher highs and much lower lows. Feelings that come from your body, which start from like when you say like, how are you feeling, right? Like, what are you like? How do you feel that sadness? How do you like where that stuff starts from?
Physical body.
But how do you feel hunger? Or like that's like, how do you feel thirst? Like that's a physical feeling. Like it's right here. I can like I'm hungry, right? Like I don't know, it's right there, right? Well, so stuff like sadness and joy and grief and anger like can also be grounded in a physical way like that.
Mind-body connection.
But if it's grounded in your mind and your thoughts, right? It's much more like you can be so much angrier towards an idea, right? And that'll generate an intensity in your body that's really about something you're thinking about that isn't necessarily it's what you're thinking about, what they did to you, much more than the actual situation that's created by what just happened.
Yeah, probably wasn't even that bad, but your mind amplifies that.
The MAOIs worked really well for this, right? And I was thinking, okay, well, one of the things they do is there's dopamine, and then there's a specific one called selegiline that now is in a patch. And sort of bypasses the liver some, so bypasses the gut some, so it doesn't have as much of the that side effect problem. And it has a metabolite that's a stimulant. Like, oh my God, let's use that. And I started asking about it. Turns out, I dug around. There were a couple of studies, I think in 2004, done in kids, which actually showed like kind of sort of works. But there's a lot of so like yes and no. Right? There's an art here and there's a lot you can do. But what I've discovered in my own practice, in my own work, is that just the one that I see as like, I promise nobody's paying me to say this. I promise. Like we should have said this at the beginning. Like I don't take money from anybody.
We can edit it in later. Yeah, well, no, it's true.
This is like the only people who pay me are my patients.
Yes.
And the thing that I've seen work the most for most people is Vyvanse because it's got the smoothest action over the course of the day. You take it in the morning and it just like, you don't get these like highs and lows. It's smooth and even, like it wears off at the end of the day, but then there's still this sort of like ongoing benefits sort of, and you can just like, and like over time side effects kind of go away because your body just kind of gets used to it. Whereas like an Adderall XR, the long acting Adderall, because of the way it, the technology that makes it long acting is it's 2 beads that dissolve at different pHs. So one dissolves in your stomach and the other dissolves in your upper GI as gastric contents dump a couple hours later. But you just kind of like, it's like, it's basically like you put another short acting in your stomach. And when your gastric contents dump, then you get like another burst of short acting, right? Some people don't experience it that way, but a lot of people do. And so usually what I do is I start with Vyvanse because it works like why like test people to see if this thing isn't going to work when we know this other thing does work. Let's just go there first, right? Let's not waste their time, right? And for 98% of my patients, it ends up being the right answer. There are some people who struggle with it, but
John wants to say something.
Yeah.
One more.
Are we done?
So question?
Are we done?
One more question. Yeah, then we can be done.
Oh, question from the internet.
Yes.
We have one. No, Becky. We'll do Becky. We'll do Becky.
No, but she came all the way to be here in person. I feel like we love you. We love you, internet.
For the person on the internet,
like,
we'll get to you.
People who actually like got at like you know, like
the internet person might be somewhere
we'll
far
try
away.
to do the internet one too.
Yeah, we'll do it. I know. Good.
My question.
Did I answer your question?
Yeah.
Okay. Sorry, because it kind of gets
Yeah. I'm trying to figure out how to ask this. My question is about how are eating disorders and ADHD connected?
Oh, stop.
Oh, wow.
Yeah.
This is a whole nother chapter.
That was the perfect way to ask.
Wow.
That's it.
Whew.
Yeah.
Yeah, that's
I
it.
can come back next week.
What was that? Yeah, like say more. Like ask your whole question though.
I'm trying to figure out how to do it without getting a little too vulnerable.
Don't.
But I'll maybe.
Yeah, just you want to leave it there?
My question is.
Yeah, friend of mine. No. You want to?
No,
yeah.
I'm just.
You can just leave it there.
I'm curious about, like, you said something that is like I'm sort of noodling on about how there's this like ADHD like attentive thing, but then you have this hyperactivity in your like almost in your head, like in perfectionism. And I guess I'm wondering if you see more eating disorders in an ADHD sort of people than you do in the general public, and if we know why.
Okay. There's a lot to say about this.
Yeah.
So the first thing is, in trying to communicate to other people what ADHD is, right? It's very difficult because the disruption is in a system and a structure that people who don't have it don't build on purpose and build before they're 5, right?
Right.
That people with ADHD
That subconscious
didn't, right.
brain we talked about.
Right. And so when you try to explain to them that there is a set of brain functions or something that you have that is disrupted in this other person, but they don't experience that they have it. It's just the ground, right? So trying to say like, oh, no. Like there's this like, you don't understand, but you're operating based on the way this structure functions, right? The closest I've ever been able to get to explain it to people is eating disorders, because like I rotated in residency on an eating disorders unit, on an inpatient eating disorders unit. And I mean, the experience of being with people who they're so intact. They're so intact. They are like, they can have a full conversation with you. They're totally present. They can argue with you. They can reason with you. They can agree with you, right? They know that, you know, the goal of 70 pounds, like for a 5'6" adult, like probably isn't, you think I'm kidding, man. The moment that she saw that she could be 69 pounds and didn't die, her, like it changed to that's now the goal, right? Like got to get below 70. Like that was a real person.
Oh boy.
And we're having this whole conversation, and she's like, wants to take the meds. She wants to get better. And then she goes outside and is while the people who are watching them eat meals, because you have to like watch them eat meals to make sure they get their calories right, like is looking the other way, takes the butter off the plate and like starts rubbing the butter around the bottom of the plate, right, to like make it disappear, so that it doesn't have to take in the calories, right? The ability for that behavior to exist right alongside this like incredibly intact mind. So ADHD is a lot like that, where there's this, so much of the system functions in a reasonable way. So much of the system functions right is very different than something like schizophrenia or like fulminant bipolar disorder. When someone's truly manic, I spend a lot of time in psychiatric hospitals and training. Like I've seen a lot of people who are like actually manic, right?
Okay.
Like it's very different than when people say like, I think maybe I'm bipolar. It's like, no, this is different.
They don't know.
Like real schizophrenia.
Yeah.
There's no one is asking, like when you're on a clozapine treatment unit, right? Like at a state hospital, right? Like nobody's asking, is this a person who could function normally in life? Nobody is wondering if this person's broken, right? Like these people are fundamentally like unable to like act and care for themselves as adults. And everybody can see it and everybody knows it. So what do? We just care for them because we can see that they're like, there's something broken, right? And so we just try to help. But when somebody just won't stop showing up late, they just won't come on time, no matter how many feedback sessions they get, no matter how many times people say like, you have to show up on time. They just won't do it. When they can dress themselves and they come like showered and like sometimes, and they seem able to, right? Like seem able to feed themselves, right? Like, how is it that they can't just show up on time, right? Like, and that's the thing where it's like there's this higher level thing that's intact, but then this lower level thing that's disrupted.
Right.
So eating disorders is like the closest I've ever come to being able to say like, it's like that.
Talk on the mic,
but there's,
so that they can.
Okay, but there's another. So then you asked about like how often do they actually overlap clinically, right? How actually see them together. So this is another really interesting one, because attention, I would argue, is the highest function of the human mind, right? Like you could make an argument for like spiritual metaphysics, right? But if you think about what it requires to be attentive, right? You have to take in an incredible array of information from the outside world, an incredible array of information from your inside world. You have to have done a lot of automated behaviors like eat and sleep and drink water so that your system is functioning like optimally, right? And then you have to know what you want to pay attention to, and you have to then, and that awareness has to then mute, like all the non-relevant stimuli, but not any of the relevant stimuli while you do a task. I mean, it's just like, that's like, if there's like, that's consciousness, right? Like that's
totally.
like, that's the, right? Like, so anything can disrupt that. You can be too iron deficient to focus. You can be too sleep deprived to focus. You can be too hungry to focus. You can be too angry to focus. You can be too sad to focus. You can be too in love to focus, right? Like, I mean, anything, right? Like anything. You can be, like you can be too, I don't know, like your shoelaces are untied and you can't focus because you're tripping, right? Like you can be anything. You can be too cold to focus or too hot to focus, right? Like anything.
Adulting is hard.
Somebody with an eating disorder is always going to struggle to like pay attention because they're not eating, right? So their system isn't right. Like it just like somebody who never drinks any water or doesn't breathe air is going to struggle to pay attention, right? Somebody who's chronically sleep deprived, like you could, right? Like just insomnia, right? Which is why when we diagnose ADHD, one of the things we do is like, a lot of times, actually, I've had a lot of patients where it's like, oh, no. Like, yeah, it sure looks like ADHD. It really does. But what it is it's insomnia.
Oh, wow.
Right?
Okay.
There
you go.
Sleep apnea is a really good one.
That's
a really good one. Chronically disrupted sleep will absolutely show up with symptoms of ADHD, right?
I love this. The best part about this is for people online. We got a good crowd here, and it's a networking event. So you can stick around, right? Come to Sound Union.
Awesome.
Check out. So everyone, thank you for buying tickets.
One last
we have a
question.
question from the internet. So yeah,
not so much from the internet, but
I gotta finish this. I gotta finish it. Okay. But there's this other thing, which is, and this is something I kind of discovered. I'm kind of proud of this one. Is that not eating, just like not sleeping or not drinking water, can be like a hidden hyperactivity.
Yep.
Now it's
there you
right.
go.
So now it's right. So it's not hyperactivity in the sense of like I'm generating intensity by. It's like this. If you don't eat, your system will get on edge, right? And if you seek adrenaline, if you seek cortisol, if you seek a sense of stress to achieve a sense of calm, then your body will, and this is one of the things where ADHD becomes disruptive. Yes, but it focuses you, like, so the audience member said, it focuses you. Yes, it does focus you, but at consequence. That's the problem. It's not going to be a kind of focus that's sustainable. If what you require is that kind of intensity in order to focus, because you're not going to be able to learn that well because your body's in a state of hunger. So it's not going to be operating optimally to actually learn. So like, but this is where you get the like always flying by the seat of your pants, struggle to automate behaviors thing, which is why you have to start from a place of a consistent daily rhythm, where you let go of even trying to like, I'm going to now is the time to like start my new business, right? You have to go back to the routine, like back to basics, because it's been disrupted since you were 4. And so your body has the signal to sleep, the signal to eat, the signal to drink water.
Listen to it.
It isn't really that. Your system has learned at a level just below consciousness that that's a signal to not eat. Because if I'm hungry, if I don't eat, I'll somehow get calmer. Right.
Keep that stress.
So anyway, I hope that answers your question.
Internet. We got an internet. It's great. We got someone online.
Just the last question. What advice do you have? What advice do you have for parents?
I think you should open something loud.
Yes,
in the
exactly.
audience. We should do.
The internet didn't hear that.
Oh, okay.
What advice do you have for parents or an adult who has a stigmatized view of what ADHD might be? I mean, we're in Silicon Valley. This is going to broadcast, wide and far. There probably are still pockets of people out there who either deny or they think it's a bad thing. So how do you get folks to come in and understand or seek treatment?
So,
or what advice would you give them to recognize it and find some help?
no, wait, that you switch it up on me. Are you talking about people who have it and stigmatize it, or people who don't have it and stigmatize it? Because you at the answer, like, well, how do you get people to come in and seek treatment? Which suggests that it's people who do have it and don't want to get treated.
Well, or they might have kids that they think, but they don't want to admit, right, that they have it, or they think they have it, but they don't want to admit that they have it because of an association of a
right. I would never demand that a parent do something that they're uncomfortable with for their child, because even with all the things that I can do to help somebody with ADHD, I will be the first to acknowledge that there are side effects to medicines.
Right.
Like there are consequences to these things, right? And some of them we may not even, like there may be side effects that are like, well, if you're exposed to it for 40 straight years, then this, right? At the same time, I feel comfortable doing what I do because I've seen how it just completely changes someone's life in a way that lets them be more themselves, lets them grow and mature more completely and more effectively without having to constantly be like fighting against themselves to do anything, right? But if a parent is reticent, like that's okay. Like that's okay. Like they're allowed. If somebody doesn't think they have it and so doesn't want to go get assessed and treated, like that's fine. That's fine. Like if your life is working for you and there are people around you who say it's not working for them, well, maybe you two just don't work for each other, right? It's possible. Like at the extreme, it'd be like alcoholism, right? Like you need to stop drinking. Everybody's telling you need to stop drinking. You don't want to see it. It's like, well, okay, if you want to light your life on fire, well, I guess we'll just let you do that. But ADHD isn't always going to be that extreme, right? People aren't necessarily lighting their lives on fire. Or like if it's a life, if they're happy with their life, like that's allowed. Like you're allowed. These aren't like, it's only a problem if you think it's a problem. When somebody comes to me asking for help, if they say to me, "Doc, you tell me what's wrong with me," my immediate answer is like, that's not within my power, or like, I don't live your life. Like there's so many details in your day-to-day life that I don't have access to. Like if you had schizophrenia, right. Then that's exactly what I would do.
It's a little more cut and dry.
But then you definitely don't know you have a problem. Right.
Yeah,
And it's real clear to everybody else that you have a problem because you're like not eating or showering. Like you're not, right. Like you're, like you literally haven't showered in like 8 months, right? Like I had a patient anyway.
So the takeaway is up to the individual to really kind of understand, especially as an adult, how they might be able to seek treatment. And
if it's bad enough that treatment needs to be forced on someone, we have structures for that. There are things
that doesn't happen, does it?
False.
Okay.
False. Okay. It's things like handcuffs, right? Okay. What are handcuffs? Handcuffs are a signal that society has decided that you can't be trusted with the operation of your hands, right? If which, and obviously they're like used sometimes in situations where they're totally inappropriate, but like that's the fundamental signal, right? There are all kinds of situations where society will say you don't get to choose anymore because we no longer will let you choose. And we can have lots of in-depth conversations about the times and places where that's appropriate, where it gets overused, where it gets misapplied, where it's like, there's going to be all kinds of systemic like problems in how that gets misused, right? But if someone is not in a place where society is stepping in to prevent them, then they're allowed. I don't know. And then there's also arguments about like, the whole Me Too movement. There's arguments like, okay, well, people weren't stepping in to prevent stuff, but they should have been, right? And like, okay, so that's stuff we need to work on too. When it comes to ADHD, if someone isn't hurting other people in a concrete way, and they don't want to deal with it, like I'm not going to force them to. I don't know.
That's true. No, that's very well said.
To dance around that a lot.
And boy, we went, almost an hour and a half.
I think there were more questions too.
Well, I tell you what, I think you can stay, right? So we're gonna have a networking event. And, there's some adult beverages.
Play some music.
We're gonna play some music too. All right. Thank you all for coming. And folks online, check out your website. www.Aaron Winkler, Aaron with 2 A's, Aaron Winkler MD And
I developed the symptom tracking process.
Yes.
The website's still we're updating right now, but so it's not live for it's gonna be live again in a couple of days. But
it's not. I was on there today.
Yeah. Oh yeah. But we're revamping something.
Okay.
It'll be live again in a couple of days.
Check it out.
So that's castadhd.com. CAST.
CastADHD.
California ADHD symptom tracking.
All right, hey, thank you so much. This was really
That's fun, man. Yeah.
Dr. Aaron Winkler, everybody.
Yeah. Nice.
And I think we're out. Are we out? We're not.
We're not
We're
out.
still broadcasting.
Not out.
So that's the lovely thing of the internet. Okay. Thank you.